Hello guys, good morning. This is after a long time I'm creating a video. I thought I'll start with something basic but yet tricky. Why tricky? I'll let you know in further slides, because there is always a confusion regarding how to pick up, what are you supposed to do during the examination. Because to tell you do the examination of abdomen system is straightforward, easy. But when you are given a scenario where you can't decide what you should do, then it becomes tricky. So you may lose mark of doing completely wrong thing, though examiners will give you a hint, and sometimes people fail to pick those hints as well. So that is very important. So abdominal examination per se is not difficult. I'm not going to teach you here the abdominal examination. You already know that how to do it. It's a basic medical school teaching: inspection, palpation, percussion and auscultation and everything. But how to deal and how to approach the patient or scenario, that is more important. So let's see. So there will be two kind of expected scenarios. Either it will be acute or kind of an elective, or it would be rather in ward in ITU or maybe in OPD. So what happens if a patient with, say, umbilical hernia or sort of any abdominal pain is referred to you in OPD, or is coming to see you first time in OPD? The examination is definitely not expected to be of a patient who is unstable hemodynamically. So generally these patients will be maybe having some pathology. Here we will have role players during the exam, in real exam, and they won't be putting critical patients actually anyways in the exams. So they will be role players. So they will be giving you hints from their facial expression to their verbal expression and all. But in the first minute reading outside the station bay, you will be given this scenario that this patient is coming to you in OPD with this complaint, or has been referred by a GP, something like that. Then you can understand that most likely this would be a straightforward abdominal examination with some findings possibly there. If it is something which is patient has been operated, is in ward and now developed some issues, or patient is already in ITU or something like that, then definitely it is something acute and you have to approach accordingly. So here the hint is that possibly you are not only dealing with the abdominal examination, you are dealing with CRISP station. CRISP is you should not say CRISPA, that is short form we use, but it is basically care of critically ill surgical patients. So you should be very well aware with that approach, and then you have to act accordingly in the stations. They may not give you direct hint that you have to do the examination according to the CRISP protocol, but you have to understand that this is a scenario which demands CRISP protocol. So that's the basic difference between the abdominal examination stations. You might have like 7-8 different scenarios. Then you have to pick up whether am I supposed to do the routine abdominal examination only, or am I supposed to shift to the CRISP first and then maybe coming back to the abdominal examination. So what happens in CRISP, you are dealing with the critically ill patient, then you have to look at the surroundings first. There may be charts given, there may be oxygen cylinder given, there may be patient who is having breathing difficulty or is in severe pain. The patient's facial expressions are that. Then you have to pick up from that here you are not supposed to touch the abdomen directly, okay, unless you are given some hint. Then you have to start as per routine abdominal examination. So you have to read between the lines, look at the surroundings, shift to the CRISP if needed. Use your common sense, that is very much important. If you feel so this patient is something, it's not a routine abdominal examination, if your gut feeling is that, go do it accordingly. If it is your gut feeling says no, this is straightforward examination, act accordingly. Okay, there is no rocket science in this, and people are generally, because of the anxiety of exam and nervousness, they may make these trivial mistakes. So this can be avoided. You are not going to lose marks just to be like doing a wrong thing at first if you just correct it in time and then you save your time. The only thing is that these beginning mistakes will make you more nervous, and then the station may not go according to what you could perform otherwise. So that is more important. No need to verbalize the examination findings. Generally, people have very much confusion about this, whether whatever I'm doing, I should be speaking to the examiner or no. No, examiner is watching you, observing you. What you have to do, you have to communicate with the patient as per the demand of the station. Here you are not taking history. Here you are just introducing yourself, wiping your hands using sanitizer, then informing the patient about what are you going to do, what are we supposed to do here. Then take a verbal consent from the patient, that is it okay, if they are okay, and are they in pain right now, do they want some painkillers in the beginning, or if it is okay, then you can proceed. And then when you are proceeding, your communication with the patient must be in empathetic way and in a layman language. So all those things, though we do not have a layman examiner here, the clinical examiner is observing all these things. So most of your marks are based on the communication, the approach, and I would say around 8 marks out of 20 is only for your technique of examination. So again, believe me, 12 marks are for 4 marks are for clinical knowledge and communication with your examiner at the end of the station. You have 9 minutes, 6 minutes of doing this exam and 3 minutes to face the examiner. So the last 3 minutes are not that very important. I would not say that you should not be preparing that, but if you have performed very good in those 6 minutes, you are definitely going to pass the station. That's what the basic concept is. So how would you pick up between the lines? I mean, if you see the patient has been operated, some anastomosis or some major laparotomy was done. Now this patient is developing some breathing issues, and you are asked to do the examination of this patient. Patient is in pain and all, whatever. You will see the charts, or the charts reading must have been given in the scenario itself, that patient is not looking hemodynamically stable. So what is your first thing to make sure? You will make sure that you are dealing with a patient who could be critically ill and become hemodynamically unstable. So your first thing to do is, yes, ABC protocol by CRISP. So here, by going inside the scenario after introducing yourself and doing all those small stuff of wiping hands and everything, you're not going to do the abdominal examination directly. Here you want to make sure that patient is breathing well, conscious, alert, and there is no breathing issue, airway saturation is like okay. So if there is no added sound in the respiration, patient is talking to you and the saturation is fine, then you can go to circulation. So see, if it is like a case of pulmonary embolism developed after patient had some surgery, so you might be given some hint like the anticoagulants were not started, or they were started but there was not enough dose, or maybe everything was fine but some doses were skipped in between by mistake, or patient is not wearing a DVD stocking. Then you can think in line of maybe you are dealing with a pulmonary embolism. So here the ABC, airway would be clear, but breathing would be like patient is having tachypnea, saturation might not be normal, there would be tachycardia. So in these role players, how would you identify? So you will just say that I want to see this, maybe. Then the examiner or the charts would be there which will tell you the findings, that this is the finding. Then you have to act accordingly. So don't confuse yourself, oh this is a role player, then how will I get a finding? No, you will not get a finding, but you will have some information given on that. Okay, so don't worry about that. It will not be something haphazard. It will be a clear-cut guidance for you that what is the finding, and accordingly you will judge your scenario. After that, definitely when you finish ABC, the next comes D and E. In that CRISP protocol, you have to basically look at the operative site also and all. I'm not going into details of CRISP. There are so many videos available on YouTube for CRISP approach and everything, and they are excellent videos, so I don't want to repeat those things again and again. You can just have a look on them, and then you'll have idea how do you do CRISP examination, or how do you follow the CRISP protocol. And mind it, never use crisp word as a short form. Always say care of critically ill surgical patients. For our convenience, we use this short acronyms, but it should not be used in exam. Be aware about that. Sometimes you will not get the normal range of lab test which may be given there. So always try to make sure that you are following a UK system which may be different from your country, of maybe a standard units or maybe something different than, like in creatinine. In India we use milligram per deciliter, they may be using millimole. So you have to make sure that you are well aware with the normal ranges and the units which are used in UK. So nothing to be worried about it. There's common things like CBC, hemogram, create, liver function test, blood gases, those things, those parameters you should be well aware of about the normal ranges. And then you go for the abdominal examination if you already operated and you just do superficial examination, and then you find that abdomen is completely soft, there is no issue, and you are dealing with the respiratory issues of the patient, then it is most likely a case of pulmonary embolism. If not so, there is tenderness, patient is not, very comfortable, even on the superficial palpation, patient has pain. Stop doing the examination completely, just do auscultation lightly and tell the examiner that patient is having severe pain or tenderness or guarding, so I'm not able to finish it off. I'll do further checking with the imaging or so. And if the pain is like patient has come to you in OPD setting, or you are seeing the patient in accident and emergency department where a patient has been referred with acute pain in a particular quadrant or abdominal region, like in the right iliac fossa, pain for appendicitis, right upper quadrant pain for this acute cholecystitis. So again, people will have confusion, like if the superficial tenderness was positive, should I go for the Murphy's sign? No. If already you found that there is tenderness, then you should not do that again. Don't cause pain twice in the same region. That's the simple thing. Then tell the examiner that as patient had tenderness in the right upper quadrant, I'm not going to look for the Murphy's sign, or otherwise I would have liked to do this examination. Same goes for the acute appendicitis. If superficial palpation, there is tenderness on the right iliac fossa, you'll not go for the rebound tenderness and all. Okay. And then whenever patient is telling you, before beginning, you will always ask whether they have some pain in particular area or where is it located. They will tell you that they have pain in the right iliac fossa. Then you will start your examination from the left iliac fossa and coming circularly anti-clockwise, and always the pain area last. That's a normal abdominal examination technique. Okay, so I'm not going to into details of those. Then abdominal examination, as you all know, inspection, palpation, percussion, auscultation. Again, if there is tenderness, you are not going to percuss that area as well. So that's a normal common sense. Okay, then you have to summarize your case findings after 6 minutes. 6 minutes sometimes may not be enough for examination stations. In my exam, out of 3 examination station, in 2 I could finish, and 1 I could not finish the examination station. So sometimes they can be long, but whatever you are doing, if you are doing it correctly, they will consider it well, and it's not always necessary to finish the examination. Okay, so don't worry about that. Don't be scared about that. Oh, I could not finish my all the steps for examination, I will lose mark. No, you will not. It is about your approach, your empathy, your communication, your common sense, and your professionalism. Everything is counted here. Okay, all the best. Be well prepared for this, and hope you will do great for these stations. Thank you so much.